Hi everyone, here is my presentation about Thailand's universal coverage scam case study. Here is the background of the case study, which is many healthcare system fails to protect families from the financial burden of paying for medical treatment, and over 35 nations spent more than half of the entire health budget on out-of-pocket expense in 2012. And in Thailand, prior to the universal coverage scheme, a quarter of the population lacked insurance and others were protected by insurance that only provided a portion of their needs, and one in five of the poorest Thai households now falls underneath the poverty line, and over the 17,000 Thai children under the age of 5 died each year from different disease, especially infectious disease, which may be easily prevented. In regards to rollout, CS in 1975, the government had health service available to the poor free of charge, and recognizing the problem of lack of health center in rural areas. Between 1982 and 1986, the government froze all new capital investment in urban hospitals, and it reallocated those resources to rural district hospital and health centers. Also trained and employed doctors and community health workers and health providers, and recruited and trained village volunteers to strengthen primary care. In 1997, Asian financial crisis exacerbated the effects of inequitable health coverage and weakening the Thai economy along with its health system. In 1999, government and civil society proponents of universal health coverage saw an opportunity to push forward a radical change in how Thais access healthcare. And to prevent overlap and equity, the government planned to merge resources for four existing health coverage schemes. And in 2001, despite progress, about 25% Thai people were still without insurance, and the distribution of coverage was unequal, and medical indicators mirrored this inequality. The government proceeded with quick implementation despite World Bank and WHO consultant that advised to adopt gradually. There were four different health coverage scams in Thailand that were merged together: the medical welfare scams, the health card scam, the social security scam, and the civil servant benefits scam. The government compromised and combined the funds for the MWS and HCS programs for the privileged and underprivileged in order to maintain momentum, and rollout was swift. In mid-2001, starting with the six provinces, by the end of the year the scheme was extended to nearly all Thailand's 75 provinces. By 2001, the USCS was covering 48 million members and families, less than 2% of the Thai population without health insurance coverage. The scam was primarily financed by general income tax, which proportionately more funded by the rich than the poor people. And initially, users paid co-payments of $0.7 per visit. However, the expense of collecting the co-payment ultimately outweighed the income it brought in. And in 2006, through doing away with the co-payment, the incoming public health minister was able to demonstrate the commitment of his party to the UCS. There is some UCS impact. First one is access to healthcare, which is the important one. Increased utilization of healthcare service by uninsured Thais, particularly those with less income, and the poorest reproductive age women and their children benefit greatest. The connection between poverty and childhood mortality has disappeared, and some households below the poverty line as a result of health spending, but the number decreased from 2.7% to 0.5% in 2000. Here is the summary of government overall expenditure on health, which from 2001 to 2002 it increased to $3.6 billion, and in 2008 increased continuously to $7.6 billion. And the UCS funded by the government of Thailand through revenue from general taxes, the budget increased in both absolute and per capita. In 2002, the government allocated $35 billion, which is increased in 2012 to 80. And in compared to comparable upper middle income, Thailand has achieved near universal coverage at a cost to government that is marginally than the country's GDP. Some reason of success of this intervention, the UCS was maintained by dependable and committed leadership. The Thai Party gained popularity and maintained its dominance due to tangible advantages which allowed it to develop and enhance the programs. Thai reformers picked up lessons quickly from international experience, and government made central purchases of drugs and equipment by taking advantage of massive UCS coverage to negotiate for reduced costs. And the Thai government has already begun constructing the health infrastructure before the UCS launch. The government was able to accommodate the additional demand under the plan due to those prior advancements. Funding allowed public facilities to offer more comprehensive healthcare service, and at last the health service and technology that the program would cover were carefully chosen by nation. Here is some implication of the study. Thailand's UCS was implemented quickly. That shows countries with a lower middle income may attain universal healthcare. The prioritizing of health intervention is evaluated by a broad panel of health professionals in order to make policy formulation participatory. Most Thais enjoy free health insurance with tax money used to pay for these benefits, and experience has shown that access to free healthcare does not automatically result in greater health. Additional factors must be present, and Thailand was able to maintain its population healthy and save young lives by offering free and economical service while boosting its healthcare system. And at last it can serve as a guide and source of inspiration for other nations pursuing universal health. Uh, Here I'm going to apply implementation science, research framework, and evaluation on this case study. Implementation science research present a method for comprehending and addressing health inequality by using evidence-based, context-specific treatments. I'm going to apply two different frameworks. First one is REAIM, which is Reach Effectiveness, Adoption, Implementation, and Maintenance. It is created to address the problem that the application of scientific advancement to practice has been uneven and insufficient. And Proctor frameworks, naming, defining, and operationalizing implementation strategies, include 7 dimensions, as implementation strategy must be described by their component and usage by the applied in real-world setting or research setting. It's categorized of 6 implementations outcome, which is acceptability, adoption, appropriateness, feasibility, fidelity, and implementation. I believe this case study has successfully utilized the REAIM frameworks. In case of REACH, the UCS has 48 million members by 2011, and 98% of the population was covered. In case of effectiveness, this case study intervention increased healthcare access for Thai citizens. The UCS decreased financial risk as well. And adoption, in order to advance the fundamental transformation in how Thais obtain healthcare, the government and civil society advocate for universal health coverage, identified an opportunity the government proceed with rapid implementations. And implementations, the government shifted financial funds to rural district medical center, hired and trained physicians and community health workers, and recruited and trained village volunteers. And in case of maintenance, they extended the coverage to almost all 75 province Thailands. As I mentioned, Thailand has 6 different criteria, and the outcome of the intervention based on factors are clear. Accept because increased healthcare access for Thai citizens, especially for children and women aged 20 to 30 years old, and those with the lowest income, increase their use of health service. In case of adoption, Thai's policymakers were eager to learn from overseas experiences, existing Thai's health program, and in case of approval, studies showed that UCS increased health and financial risk after its implementation reached fewer Thais, and Thailand was able to keep its health saving lives by offering and cost of treatment, so developing its health system. And fidelity percentage of cost per household increased from 2.7% in 2000 less than 0.5% in 2000, and inflation government provided around $35 billion each recipient in 2002, which increased to $80 billion in 2012. The other implementation science that has been applied in this case study is scale-up, which is defined mechanism by which health intervention proved to be effective on a limited scale and or under controlled setting are developed into larger policy or practice under concrete situations. As policymakers, providers are pressured to save expenses, enhance social consequences, and offer an explanation for why it has been so challenging to expedite the adoption of best practices. These elements of implementation is garnering more attention. Scaling up include multiple clearly defined phase, much like initial implementation process, which first one is creating a plan for scaling up, second is establishing scaling up enabler, and the last one is putting in place and maintaining the scaling up process. Before an intervention in a scale up, reliable facts and proof are required. This contains proof that it has previously worked successfully and that this is probably to continue. Evidence can be utilized to persuade others that intervention is credible and to create demands for its implementations. And at last, continuous monitoring and assessment should be done, especially in a global context. Also, this case study has been successfully utilized scaling up implementation. First, the government created a plan as they froze all new capital investment in urban hospitals and reallocated those resources to rural district hospitals and health centers, trained and doctors and community health workers, and recruited and trained village volunteers to strengthen primary care. The terms in the history of public health republics, Thai Rag, Thai Party, and Dr. Sangh Nithairam would eventually be in charge of the UCS deployment were the inter of the campaign. They all in a lot of effort in the year before the 2001 election to convince people to support universal coverage, both in politics and general public. Thailand has attained fairly universal coverage at a little lower cost to the government proportion of GDP than comparable upper-middle income nations like Colombia and South Africa. Utilize experience of international countries of insurance coverage, and the Thai government has already begun constructing health infrastructure before to the UCS launch. This prior enhancement aided the government in meeting the scam's rising demands, and UCS had 48 members by 2011, which means more than 98% of the population was covered.